Right. Well, good evening, everyone, and good morning from Houston. My name is Caitlin Furman. I'm the Director of Education and Training for Houston Methodist Global Healthcare Services, and it is my great pleasure to welcome all of you to today's webinar. We are delighted that you're joining us for what promises to be an informative and engaging session today on hormone therapy. Would like to begin with a special thank you to Rofaida Women's Health Organization for the opportunity to collaborate on this educational series. Houston Methodist and Rofaida have been longtime strategic partners and really have a shared commitment to sharing international healthcare standards with our esteemed colleagues across the region. And so we truly appreciate this opportunity today to get together with Rofaida and share knowledge and best practices. We are especially honored to feature Dr. Erin Manning, whose expertise in hormone therapy brings tremendous value to our conversation today. Dr. Manning is a graduate from Southwestern University in Georgetown, Texas, with a degree in chemistry, and she went on to complete her medical degree at Baylor College of Medicine here in Houston, and then completed her residency training at Georgetown University in Washington, D.C. She came back to Houston in 2001 to practice obstetrics and gynecology here in the Texas Medical Center, and is now with the Houston Methodist Hospital as part of our gynecology department and is a certified menopause practitioner. We are truly grateful for the opportunity to hear from her today. As far as the session goes today, Dr. Manning is going to give her presentation. I'm about to turn the floor over to her. She will give her presentation. As you all have questions throughout the session today, please feel free to use that chat or the Q&A function in Zoom to share those questions. We'll reserve some time at the end to address those. And then we'll come back with a quick close and a save the date for a future session. So thank you, Dr. Manning, for being here. I'm going to stop sharing my screen and turn it over to you.
Thank you so much. Let me get my screen shared. Let's see. You see that, Caitlin?
Right.
Great. Okay. Well, good evening. Thank you so much for inviting me to speak to you. I've been looking forward to sharing this talk with you on menopause and hormone therapy. In it, I plan to share with you my approach to caring for menopausal women, and then I'll spend some time reviewing the various hormone therapy preparations that are available in the United States. I will plan to leave some time for questions and comments at the end of our time together. I'd love to hear about some of the challenges and issues that you are facing as clinicians as you care for midlife women in your own country. I have no financial disclosures. So let me start by saying that menopause is having a moment, at least in the United States it is, from the press to social media to influencers to podcasts to books. There's an increasing discussion in the public forum about menopause and hormone therapy. You know, for the most part, I think this is a good thing for women's health. Menopause has been a long neglected and taboo subject in our society, and it can be a particularly challenging time in a woman's life. So I think having public discourse on the topic itself should certainly benefit women's health. However, I do have some concerns about this current information trend. Number one, along with good information, there is also some misinformation being circulated. And number two, this can be a particularly vulnerable time in a woman's life. And, you know, anytime we have a vulnerable patient population, I feel like there's potential for that population to be taken advantage of. In my country, we're seeing an increase in direct-to-consumer marketing of supplements, devices, and products claiming to safely treat menopausal symptoms, often without supporting scientific evidence. We're also seeing an increase in fee-for-service menopause clinics that purport personalized menopause care by testing hormone levels and prescribing compounded hormone therapy. This can lead to unnecessary expenses and, more importantly, presents a patient safety issue. So what are we to do as clinicians? Well, today I'm going to tell you a little bit about how I approach the care of menopausal women in my practice, I'll go over some of the more common questions and misconceptions I encounter and how I handle those situations. And then I'll spend some time reviewing the various hormone preparations that are available in the United States. But first, let's have a quick refresher course on the menopause basics. So remember, we call a woman postmenopausal when she has gone for 12 months without a menstrual period. Perimenopause is the time period between the late reproductive stage and the postmenopausal stage. It's typically characterized by abnormal bleeding with or without vasomotor symptoms. Now, remember that menopause is a clinical diagnosis. We rarely need any blood testing or imaging or other studies to make the diagnosis. And finally, I like to think of perimenopause as the backside of puberty. And let me show you what I mean by this. So this is an explanation that I like to use with my patients, and it does seem to really resonate with many of them. I'll admit it's a bit simplistic from a purely scientific standpoint, but it does tend to get the point across. And this is what I say. We'll see if I can get my hands in here correctly. So when you think of female hormones level when you're 6 years old, they're down here. When you're 26 years old, they're up here. When you're 66 years old, they're going to be back down here. Well, you don't just go from 6 to 26 in a day. You go through what we call puberty. Hormone levels go up and down and up and down and up and down till they get here. So same thing. You're not going to go from here to here in a day. Hormone levels go up and down, up and down, up until down till they're back down here. So that's what we call perimenopause. And so I like to use that explanation with my patients, and many times I have kind of a little bit of an aha moment when we have that conversation. So keep that one in your back pocket. So a bit about the timing of menopause. So the average age of the final menstrual period is 51.5. But remember, anywhere between the ages of 45 and 55 would be considered normal for the final menstrual period. And remember, the symptoms of perimenopause can begin anywhere between 2 and 5 years before the final menstrual period. And the average number of years of symptoms is 7.4. Now, speaking of symptoms, there's a lengthy list of symptoms that may or may not occur during the perimenopausal transition. Some women have severe debilitating symptoms for decades, and some women have very few symptoms at all. Those are outliers, though. Most women will have a good 5 to 10-year window of perimenopausal symptoms. I've divided the list of symptoms into 3 columns just to kind of help us organize things in our minds. So the first column on the left, the green column, those are the symptoms that are really most easily treated by hormone therapy. Now, the middle column, the yellow column, those are the symptoms that sometimes improve with hormone therapy and sometimes don't. And finally, the far right column, the red column, those are the symptoms that are more than likely not going to improve with hormone therapy. And now finally at the bottom, I separated out the symptoms of genitourinary syndrome of menopause. Now remember, those are the symptoms that can be treated with vaginal hormone therapy or systemic hormone therapy. And we will review those various preparations. But my point to this slide is I think it's important that we as clinicians listen to and acknowledge all of the symptoms that our patients are presenting with. But I also think it's important that we are honest and transparent with them about what symptoms we can really help and what symptoms we may or may not be able to improve, or maybe we need to address those specific symptoms with alternative options. So I'll tell you a little bit about how I approach a patient who presents to me for a menopausal consult. So I almost always start with a menstrual history. Many patients will walk in with a long list of symptoms they've been compiling, want to jump right into that discussion. But I really try to redirect the conversation back to the menstrual history, if at all possible. I do that for a couple of reasons. Number one, I want the patient to understand the importance of the role of the menstrual history and what that plays in the discussion. And number two, it helps me organize that patient in my mind and try to figure out early on in the conversation where she is in that process. Now, if the patient is tracking her periods regularly, then this gives me an opportunity to commend her on taking such good care of herself by tracking her periods. If it doesn't sound like she's tracking them, then it's an opportunity for education and encouragement. Next, I'll go on to a discussion of symptoms. Most of the time, I just ask right off the bat, you having any hot flashes or night sweats? And then I follow up with, any other symptoms that you think you might be associated with perimenopause. I don't usually end up needing to read a lengthy checklist. Most patients, by the time they get to see me, they have already read up on menopause. They're aware of the potential symptoms. So I really do try to get a good handle on the specific symptoms that they're having and how bothersome each of those symptoms are, and really try to document that specifically in my notes. For example, she reports 10 to 12 hot flashes a day, or soaking through the sheets at night, or can't get through a meeting at work without, having to change her jacket. So I'll document that very carefully. And that way, if we end up starting hormone therapy, then we can circle back to the symptom list and see which symptoms have improved and by how much. I'll also include the remainder of the medical history and a physical exam. There is a trend towards virtual menopause care in my country. However, I do still feel pretty strongly that a physical exam is an important part of the visit, especially if I end up prescribing medication. In some patients, I will end up doing a pelvic ultrasound in the office to evaluate any kind of bleeding abnormalities. As you well know, this is common during the perimenopausal transition. In my current practice setting, we actually have multiple ultrasound machines and sonographers who are available to perform ultrasound studies, which is quite a luxury. This allows me to review the results and recommend any further testing, all on the same appointment day. So what next? So now I've taken the history, I've reviewed the symptoms and the past medical history, performed a physical exam, possibly done an ultrasound, and what do we do next? Well, as I was preparing this talk, I came up with this little chart that I thought might be helpful for our discussion. So normally by this time in the visit, I already have an idea in my mind whether or not I think the patient is a good candidate for hormone therapy and whether or not I think she would benefit from it. And most of the time by this point in the visit, I can already tell what the patient wants too. In other words, most patients these days already come into my office having already read up and already decided whether or not they would like to start hormone therapy. So this chart kind of helps us organize the different patient scenarios. So on the top horizontal axis, I have Manning yes, Manning no. So Manning yes means I think hormone therapy is a good idea for the patient. Manning no means I think hormone therapy is not a good idea for the patient. On the vertical axis on the left, I have patient yes and patient no. So patient yes is the patient who comes in, wants to start on hormone therapy. Patient no is the patient who comes in and doesn't want to start on hormone therapy for whatever reason. So this chart gives us 4 different patient scenarios. I'm going to go through each of these different scenarios and talk you through my approach. I'm going to start with what is, for me, the easiest scenario first, and I'll end with what is the most challenging patient, or at least the one that's the most challenging for me. So easiest patient, in my opinion, is top left corner. Manning yes, patient yes. So this is usually the patient who comes in, she's symptomatic, she has no contraindications to hormone therapy and would like to start hormone therapy. Those patients, I do typically spend a few minutes discussing the risks and benefits. Even though most of them have already read up on it, I think it's our obligation as clinicians to review relevant data and potential side effects. We'll then discuss hormone therapy options. I send a prescription, and then I typically will set up a telemed visit in about 4 to 6 weeks to discuss efficacy and any side effects. This has been a really nice addition to how we practice after COVID. We have a lot more opportunity for telemed visits. And so we are able to follow up on these patients and see how they're coming along on the medication much more easily. This is where the careful documentation also comes into play. So during the telemed visit, I typically review the symptoms that the patient originally presented with and see how those symptoms have changed, hopefully improved. And then we may discuss a dosing change or any side effects. And then, assuming she's doing well, follow up in a year. So that's the easiest patient. Next on the list is the bottom right-hand patient. That's Manning no, patient no. So these are usually patients who have a known contraindication to hormone therapy, such as a prior thromboembolic event or estrogen-sensitive cancer. Most of these patients already know that they're not a good candidate for hormone therapy, and so the discussion is not particularly difficult. Or sometimes the Manning no patient is someone who is completely asymptomatic and maybe has a relative risk or a relative contraindication to hormone therapy, like maybe a strong family history of breast cancer or something like that. So this would not be an absolute contraindication to hormone therapy, but if the patient is completely asymptomatic, then really no reason to start hormone therapy. Now, for the Manning no patient who has symptoms, now she's usually someone who I would have a conversation with about non-hormonal options for symptom management. We do have a really nice number of non-hormonal options for management of menopausal symptoms. Those options are beyond the scope of this talk today. Now, the next patient to discuss, a bit more challenging, that's the bottom left patient. Manning, yes, patient, no. So this is the patient who I think would benefit from hormone therapy, but patient thinks otherwise. So this is usually the patient who comes in, she's very symptomatic, all the classic symptoms of perimenopause, they're really affecting her daily life, but she's hesitant to start hormone therapy for whatever reason. Maybe her best friend was just diagnosed with breast cancer, or maybe she read that hormones can cause dementia, or maybe she just doesn't want to put any chemicals in her body. Patients come in with all sorts of biases and information. And I think in these particular cases, it's really important to kind of drill down and determine what the patient's specific concerns or hesitations are, and then try to present in a compassionate way the reasons why she would probably be a good candidate for the medication. This is an excellent opportunity to address any misinformation that she may have gleaned from her reading, and hopefully present some evidence-based information to her. Now, sometimes in these scenarios, I'm able to convince these patients that a trial of hormone therapy is a good idea, and sometimes not. Sometimes we'll end up starting a non-hormonal option first, and again, always follow up with a telemed visit 4 to 6 weeks. And finally, potentially the most challenging patient for me ends up being top right-hand corner. So that's Manning no, patient yes. So this is the patient who I think should not take hormone therapy for whatever reason, and the patient comes in wanting a prescription for it. So one scenario would be the patient who comes in with an absolute contraindication to hormone therapy. This ends up being a pretty straightforward talk most of the time after I explain the contraindication, but even so, some patients will persist and continue to ask or challenge, and sometimes I just simply have to end the conversation by saying it would be malpractice for me to prescribe this medication. Now, there's another scenario where it's not an absolute contraindication. Maybe it's just a patient who has some risk factors that make her not an ideal candidate for hormone therapy, and she's really not having any symptoms. This is likely a patient who I feel there would be very little therapeutic benefit. And so in these cases, I typically end up having a pretty detailed conversation with the patient about potential risks and potential benefits. And if after that discussion, the patient is still interested in starting hormone therapy, as long as there's not an absolute contraindication, I'll go ahead and prescribe it. And again, always follow up with a telemed visit 4 to 6 weeks just to discuss efficacy and side effect. So these are the most common patient scenarios I encounter, and we've reviewed a summary of how I manage each of them. Obviously, there are many other nuanced patient scenarios that require specific discussions and counseling. Now, before we jump into the hormone preparations that are available in the United States, I'd like to touch on a couple of other challenges that I encounter often in my practice and kind of review with me my approach to those. So what about the patient who comes in and wants to have her hormone levels checked? So this seems to be becoming a more and more common clinical scenario as of late. And as I'm sure many of you are aware, there's very little clinical benefit to checking hormone levels during the perimenopausal transition. every once in a while in a young hysterectomized patient, or maybe a patient with chemo-induced menopause, I might find it beneficial to check an FSH, but most of the time it's really not clinically indicated. So first of all, I try to find out why she's asking to check the hormone levels. Interestingly, some patients think that we have testing that actually can determine when they're going to complete menopause or when the symptoms will resolve. Some patients want to check hormone levels because they want to know if they're perimenopausal or not. Each of these scenarios, again, an excellent opportunity for us for patient education regarding the usefulness or really lack of usefulness for checking hormone levels. Now, some patients who are already on hormone therapy want to check hormone levels and see if they are on the proper dose. Now, again, education is key here as well. I usually say something like, well, I'm not treating your hormone levels, I'm treating your symptoms. So let's talk in detail about your symptoms and see how we're coming along on that. Now, there is some recent discussion in the literature about this term poor absorbers, and I've certainly observed that in my practice. In those particular patients, however, rather than checking levels, I usually just go ahead and increase the dose and see if the symptoms improved. And most of these true poor absorbers really will see some symptom improvement with just a slight increase in the dose. So now, another challenging patient that I see fairly often is the one who comes in who's already on a compounded hormone regimen. Sometimes it's pellets, sometimes it's transdermal, sometimes it's oral, sometimes it's a combination of all three. And I really tend to stick to FDA-approved regimens in my practice. So I'm not typically prescribing a lot of compounded hormone regimens. So many times this particular patient has come in and she's brought a printout of the labs that the hormone specialist has run, and she wants me to review the labs and give my opinion. So in these scenarios, I really try to go back and focus on the original symptoms that the patient was having before she started the compounded hormone therapy, and then follow up with the question, is the medication helping these symptoms? And if she says yes, then, I'll typically go ahead and validate the fact that she's feeling better and tell her I'm really glad that she's found something that has helped her symptoms. Again, I typically will then review or address my concerns about the safety of her current regimen. I don't typically refill the compounded regimens, but I will go ahead and review any FDA-approved regimens that I think would be appropriate for her, and I offer a change. If she asks me to review the blood work, I usually just kind of take a cursory glance and, again, then reinforce that we really don't treat blood levels, we treat symptoms. So those are two challenging clinical scenarios that come to mind and kind of how I try to handle them. I'm sure we could all offer a number of other challenges that we see. Perhaps if we have time at the end, you can share with me some of your own challenges that you're dealing with in your country and with your patient population. Okay, so menopausal hormone therapy preparation. So we have over 50 different FDA-approved hormone preparations available in the United States. As a practitioner, that can feel a bit overwhelming when thinking about selecting the proper regimen for our patients. So I find it helpful to organize the various preparations in my mind in a logical way. So today I'm going to walk you through that list in what I hope is a logical way that will help you sort of remember and categorize what we have out there. So first, I'm going to start with the estrogen alone preparations. And within that category, we have both oral and transdermal. Next, we will review the progestin alone preparations, both oral and non-oral. Then we will cover estrogen-progestin combination regimens. We have both oral and transdermal options there. We'll briefly review the estrogen-testosterone combinations and the estrogen-SERM combinations. And finally, we will discuss vaginal hormone therapy preparations as well. So estrogen alone are oral preparations. Now, by the way, I'm going to be using both brand names and generics today. I have no financial interest in any of these drug companies, but I think from an educational standpoint, it's really important to be fluent in both brand names and generics. So I'll be kind of alternating back and forth between those throughout the evening. First on our list is Premarin. This is conjugated equine estrogen. It became available in the United States in 1942. It's derived from the urine of pregnant mares, and it's available in following doses, 0.3, 0.45, 0.625, 0.9, and a 125. Now, interestingly, the exact chemical structure of Premarin remains proprietary information, but we know that it contains multiple estrogenic compounds with varying bioavailabilities and varying half-lives. There's no generic equivalent for Premarin and likely never will be due to its unique structure. There's been some recent literature to suggest that conjugated equine estrogen is more active in increasing inflammatory markers. And so from a safety standpoint, this is not always my first-line treatment. However, interestingly, I do find anecdotally that Premarin is sometimes superior to 17-beta estradiol when it comes to symptom relief. So again, a nice option that we have in our armamentarium. Next on the list is Estrace. This is the brand name. It is actually 17-beta estradiol. I've listed it in bold here because it is bioidentical. There's an increase in public interest in bioidentical hormone preparations. I think this is largely due to the press and social media. I think the benefits of bioidentical hormone therapy have been kind of oversold a bit, but nonetheless, it is a nice option. We have 3 available doses, 0.5, 1.0, and 2.0. 1.0 milligrams is the standard maintenance dose. I have Senestin and Menest listed for completeness sake. I don't tend to use them much in my practice, mainly because of product availability and cost. Senestin is a blend of synthetic conjugated estrogens, and the dosing regimens are listed there. Menest is an esterified estrogen, and the dosing options are listed. Now, all of these oral preparations are plant-derived, except, of course, for Premarin. Okay, estrogen alone, transdermal. This is the one where we have quite a few options. Now, interestingly, all the transdermal estrogens are 17-beta estradiol, so that means they are all bioidentical. There are data to suggest that the transdermal approach has a better safety profile. This is thought to be largely due to the elimination of the first pass through the liver. Now, I've listed all of the options here on this slide, but we will review them one by one. So first of all, we have the patch. I've listed 8 different brand names, but I think there are several other generics that I left off or that I'm missing. So suffice it to say there are quite a few patch options. Again, all 17-beta estradiol, so they're all beta bioidentical. We have a wide range of dosing all the way from 0.014 to 0.1 milligram daily. A transdermal dose of 0.05 milligrams is thought to be bioequivalent to 1 milligram of oral estradiol and 0.625 of Premarin. Now, depending on the particular patch, it's to be changed either once a week or twice a week. And again, patch placement is the lower abdomen, and we usually recommend alternating sites. Okay, next is Divigel. This is an estradiol gel that comes in individual packets. Comes in 3 different doses, and 0.05 is the equivalent to 1 milligram of oral estradiol. It's applied to the upper thigh, alternating sides daily. Application surface is about 10 to 12 centimeters, and the entire contents of each little package should be applied daily, and then wait an hour to shower or wash. Estrogel, this is another transdermal estradiol approach, 17-beta estradiol, so bioidentical. Instructions for this one are to apply 1 pump to the entire arm from wrist to shoulder. Allow the gel to dry 5 minutes, wait an hour to bathe or swim, and 1 pump is equivalent to 1 milligram of oral estradiol. Alestrin. This is another transdermal estradiol gel preparation. Again, 17-beta estradiol, so bioidentical. Instructions for use on this one are to apply 2 pumps of gel to the upper arm, from the shoulder to the elbow. Wait 5 minutes to dress and wait 2 hours to bathe or swim. Eva Mist. This is another transdermal preparation. It's a spray, 17-beta estradiol. Dosing is 1, 2, or 3 sprays daily. And instructions are to apply 2 sprays to the inside forearm daily, alternating arms. 2 sprays is bioequivalent to 1 milligram of oral estradiol. Wait 5 minutes before dressing and wait an hour before swimming or bathing. So you'll notice that each of these transdermal preparations have slightly different locations and slightly different instructions for applications. And, even though I do this all day, every day for a living, I sometimes have trouble remembering the specific instructions. So I have a little cheat sheet on my phone with photos and instructions for each preparation that sometimes I have to pull out. Here's another nice transdermal option for estrogen. It's called FemRing. Now, FemRing is a ring that the patient inserts in the vagina and leaves in for 3 months. It releases a constant amount of estradiol systemically for the duration, that full 3-month duration. We have 2 different dosing options on this, 0.05 and 0.1. Now, keep in mind, this is systemic absorption, so women with the uterus will need progesterone. There's another vaginal ring called Estring, and that is just local administration, and that's for genitourinary syndrome of menopause. We'll review that one in a few minutes. So again, here's our summary slide of all the transdermal estradiol options. I tend to use the patch most frequently. This is largely due to patient preference, ease of administration, availability at the pharmacy, and insurance coverage. But it is nice to have so many various options. So now we'll move on to the progestin alone, and we have oral preparations there. First on the list is Prometrium. This is micronized progesterone, which is bioidentical. There are 2 available doses, 100 and 200 milligrams. Next is Provera. It's kind of an oldie goldie. It's been around a long time. That's medroxyprogesterone acetate. Dosing options include 2.5, 5, and 10. And finally, Agestin, which is norethindrone acetate. And we have a 5 milligram dose there. I tend to use Prometrium most often in this category. There are some data to suggest a decreased risk of both venous thromboembolism and also breast cancer with micronized progesterone compared with the medroxyprogesterone acetate. So from a safety standpoint, I feel like Prometrium is superior. Now, progestin-only IUD, this is a really nice option for endometrial protection. It is off-label in the United States for this purpose, but there are lots of data to support its use for this. I tend to recommend this option in patients who are perimenopausal and here have irregular and heavy bleeding. Once the progestin IUD is in place, then usually the bleeding profile is well controlled. Then I can add a transdermal estradiol for the management of her other perimenopausal symptoms. So again, a really elegant way to get through the perimenopausal transition, in my opinion. Okay, next we'll move on to the estrogen-progestin combination oral preparations. First on the list, PremPro. This is conjugated equine estrogen and medroxyprogesterone acetate. We have 3 different dosing options for this preparation. Next on the list, Activella, which is 17-beta estradiol and norethindrone acetate. We have 2 dosing options on this. This actually ends up being the most common oral combo preparation that I end up prescribing. Mainly this is due to patient preference, insurance coverage, and drug availability, really. Next on the list is Fempart. Interestingly, so this is ethinyl estradiol and norethindrone acetate. So this is the same estrogen that's found in many of our oral birth control pill options. So sometimes when I'm transitioning a patient from hormonal oral birth control to hormone therapy, this is the drug that I will select. We have 2 dosing options for this. Next on the list, Angelique. This is 17-beta estradiol and drospirenone. So now remember, this is the progestin that has some mild diuretic properties. So in patients who have trouble with bloating or swelling, I might choose this option. And again, we have 2 dosing options here. And finally, the newest addition to our list is Bijuva. Now, this is the only FDA-approved bioidentical oral combination hormone preparation available in the United States. So it is 17-beta-estradiol and micronized progesterone. So it's a nice option for those patients who are really interested in a bioidentical approach and want the ease of administration of 1 pill daily. Now, since the drug is newer, we do tend to have some trouble with insurance coverage and availability, but it is a nice option. So estrogen progestin combinations, so transdermal. So we have 2 patches on the market for this, Combi Patch and Climera Pro. Combi Patch is estradiol and norethindrone acetate. We have 2 dosing options for this particular patch, and it's to be changed twice a week. Climera Pro is estradiol and levonorgestrel, and there's 1 dosing option for this preparation, and it's to be changed once a week. A couple of other oral combination pills I'd like to mention. One is Estratest, which is esterified estrogen and methyl testosterone. It comes in 2 doses. And the other is Duavie. This is conjugated equine estrogen along with the SERM or selective estrogen receptor modulator, basodoxifene. So the SERM provides the endometrial protection for patients with the uterus, thus negating the need for an added progesterone. So another nice option for patients who perhaps maybe have a concern or a side effect from a progestin. Again, we do have some, tend to have some availability problems with this, but another nice option that is available. All right, let's review vaginal hormone therapy. We've got a lot of different players in this. This is a summary slide of the various vaginal hormone preparations. As I'm sure you're aware, we use the vaginal estrogen for management of genitourinary syndrome of menopause. It is local estrogen, so not systemic. We have a number of nice options for management of this problem, and I'll go over each of them briefly. So first is Premarin cream, again, conjugated equine estrogen, comes with a little applicator. The patient typically administers 1 gram per vagina at bedtime twice a week. Estrace cream is next on our list. It is 17-beta-estradiol, also comes with an applicator, and the dose is 1 gram per vagina twice a week. And then we also have Vagifem. This is 17-beta-estradiol tablet. It's a vaginal tablet that's administered per vagina twice a week. I do find compliance to be a little bit better with the tablets rather than the cream, so it's nice that we have those options. Invexi, that's a newer player in the market. It is also 17-beta-estradiol. It's a vaginal tablet. It does not have an inserter. It's different from the Vagifem. The Vagifem has its own, each tablet has its own little inserter. The Invexi is to be inserted just with the patient's hand. This is a newer drug, and again, insurance coverage sometimes not optimal, so I sometimes steer away from this, at least first line. But again, a nice option out there. Next on the list, S-string. So this is a ring that is inserted by the patient intravaginally, and it's changed every 90 days. And again, I want to contrast this with the FEM ring that I mentioned earlier. Remember, FEM ring is systemic. The S-string is just local. So it's just for genitourinary syndrome of menopause. It's not going to help her hot flashes or her night sweats. And then finally, our final vaginal hormone preparation is Intrarosa or Prasterone. So this is actually vaginal DHEA, and it gets converted to testosterone and estrogen in the vaginal tissue. Now, there are some reports of slightly higher systemic levels of estrone and estradiol with this medication. So I tend not to use this first line just from a safety standpoint, but again, another nice option. And it's a vaginal insert that's actually inserted daily. So we'll return to the summary list of vaginal estrogen preparations. So if you'll notice in the final column, There is some variability in the frequency of the different medications. Most notably, the ring is changed every 3 months, and the intrarosa is a daily insertion rather than twice a week. We too tend to have some compliance issues with these medications. I think part of the reason is just kind of the messy factor with the cream. But I also think the twice a week dosing is sometimes harder for patients to remember. So daily dosing is, of course, a nice option for that. So this concludes my talk today. During this hour, we've covered menopause basics. We've reviewed my approach to menopause care. We've discussed some of the more difficult patient scenarios, and then I've reviewed the various hormone preparations that are available in the United States. This is a photo of the sunset over one of my favorite lakes in Central Texas, Lake Travis. If you have a chance to visit my state, please be sure to make a stop at one of our beautiful lakes in the Texas Hill Country. And I'm happy to open the floor now for questions.
That was wonderful. Thank you, Dr. Manning. We got a question during your presentation. I did want to share, we are recording today's session, but got a question about whether you'd be willing to share your slides. There's great information in here that folks would like to reference later.
Sure, happy to do that. I'll send them to you, Caitlin.
Perfect, wonderful. I think a few of these go back to some of those initial slides that you had around what therapy can help with and what it doesn't help with, but I want to ask a few of these questions. So what are the recommendations for using gel patches for bone protection for postmenopausal women over 65?
So, the concerns about continuing hormone therapy into the, mid 60s and beyond, we do have some concerns about the cardiac risk, namely thromboembolic risk, heart attack, and stroke. So certainly we do know that hormone therapy can help with bone protection, but we have a number of other options that are non-hormonal that can also help or treat bone protection. So we tend to think about weaning those patients off, during the early to mid 60s off of the hormone therapy. And then if we need bone protection at that time, discuss other non-hormonal options for that.
Does low dose estrogen prevent UTI or help in recognizing symptoms of UTI?
So, one of the part of the constellation of symptoms of genitourinary syndrome with menopause is recurrent UTIs, and anyone who cares for older women or even an elderly parent knows that recurrent UTIs can be a big problem. So, vaginal estrogen therapy is really going to be our go-to for prevention of recurrent UTIs. We don't typically need to add systemic hormone therapy for management of this. So from a safety standpoint, we can just get by with vaginal estrogen preparations. And I spend a lot of time counseling patients about the importance of continuing their vaginal estrogen preparations forever. And I end up saying forever like 6 times in the visit. And so we're usually laughing about it by the end of the visit. But yeah, I do feel really strongly about continuing vaginal hormone therapy for that particular reason.
So I'm seeing some follow-ups in the chat. Can herbal tea help with menopause?
The data on any of the supplements and herbal remedies is pretty soft still at this point. I think that we still have a lot more work to do from an evidence-based standpoint before we can really feel comfortable about recommending any kind of herbal supplements at this point. Usually I have a conversation with patients that goes something like, well, it may or may not help. And many times we'll have at least some safety data that I can look up and hopefully reassure them about the safety of it. But, as far as being comfortably able to recommend that we have evidence to show that it will improve the symptoms, I think there's still work to be done.
Could you talk a little bit about the duration of the various therapies that you've discussed? I think you touched on that about phasing that out, but kind of.
Yeah. So ideally, in a perfect world, we would start talking to a patient about starting hormone therapy somewhere around the time of that final menstrual period, whether it's, a couple years before or even 1 to 2 years afterwards. From a safety standpoint, that's usually where we'd like to start that conversation. And again, what we do know and what we've learned, from the various long-term studies is that as women age, that cardiac risk goes up. And so I tend to, in my practice, somewhere around the early to mid 60s, start to have the discussion about lowering the dose. With the eventual thought of going off. And, this ends up being a very individualized approach. And in some patients, I'll describe it to them as a science experiment, and I'll say, okay, well, this year we're going to try to lower the dose. And if you have trouble with symptoms, call me back and we'll go right back to the other dose and we'll try again next year. So again, ends up being very personalized, again, as long as the patient doesn't develop some sort of, hard stop or absolute contraindication to the medication.
Seeing lots of comments thanking you for this informative session, how beneficial that it's been.
Oh, you're welcome.
Appreciate your insights today. I am not seeing any additional questions. We'll give it another second or two. But unless anything else comes up, I think, one more. Acupuncture. Lots of alternative options, lots of questions about alternative options. So does acupuncture help?
Yeah, so there is some level 2 evidence about acupuncture. Certainly the safety data is there for sure. And there is some evidence that acupuncture can help with vasomotor symptoms. There are so NAMS, actually we call it, we're not NAMS anymore, we're the American Menopause Society, but is sponsoring several trials right now looking at non-pharmacologic options for management of menopausal symptoms. So I think more on that to come.
Dr. May, thank you so much. This has been such an insightful presentation. Truly appreciate you sharing your expertise with us today. Just a reminder for everyone, I'm going to, if you will stop sharing your screen, I'm going to share a final slide.
All right, I can do that.
Yeah, there, get this handoff together here. We have a final reminder for everyone that's on the call today. We will again share the recording with everyone, and then once we've got Dr. Manning's slides, we'll reach out to everyone and share those for future reference. We've got a post-event survey that's on the screen now, so please take the opportunity to scan that QR code and complete that survey. And then finally, we want to give you a heads up on a save the date. On September 3rd, we will have another webinar series with Dr. Pedro Ramirez. He is our chair of obstetrics and gynecology here at Houston Methodist, and he's going to be addressing innovations in cervical cancer treatment. So mark that on your calendar. We'll be in touch soon with the invitation for that session. But thank you again, Dr. Manning. We appreciate your time and your expertise today.
You're welcome.